So my name is Ryan Gentzler. I'm an assistant professor in hematology and oncology at the University of Virginia, and my focus is on thoracic malignancies, particularly lung cancer. So I think COVID-19 presents a particular challenge for us in medicine in general, but more particularly in oncology. Many of our colleagues in other specialties can delay care or close down their clinics as we get through the crisis that we're currently facing with COVID-19 and resume routine care after the risk abates. I think in oncology, we're particularly faced with the challenge of patients who have life-threatening illness and may need to get continued care throughout this pandemic. And so I think this really takes a lot of people working together in teams to sort of risk stratify those individuals to see what care can be delayed, what needs to continue as planned, and what modifications to those treatment plans can be made to minimize the risk of individuals with cancer coming in and being exposed to potential COVID-19, but also to decrease the risk of exposure from ourselves and for our colleagues and other healthcare providers by bringing large numbers of patients into a clinic or to an infusion center who may be asymptomatic carriers of COVID-19. So we've taken a broad look at all of our patients in my clinic, which is, again, thoracic medical oncology. And we've sort of gone case by case, trying to look mostly about 2 weeks in advance, identifying patients who are currently in surveillance, where their surveillance CT scans can be pushed back 1 month or 2 months or maybe 3 months in some cases. We're looking at our infusion patients to see are those that are on maintenance, particularly immunotherapy, and they're maybe a year or 2 years into their treatment and doing well and not having many adverse events related to their treatment or symptoms that need acute management, and either making a choice to bring those patients in for infusion-only appointments and doing telemedicine check-ins periodically, or potentially delaying those treatments altogether for a cycle or two and then planning to resume in the future when the risk of COVID reduces. We haven't taken a broad definitive approach. It's more of an individualized approach based on patients and their needs. And this has been very time consuming, going through the schedule and individualizing care plans for every individual based on different scenarios. So I think worry and anxiety is something that affects all of us, including all of our patients. Obviously, those who have advanced cancer have constant worry and anxiety, and we're used to managing that aspect of it. I think adding this on top of all of that underlying cancer-related anxiety has been a real challenge. And we've, at our institution, have implemented visitor restrictions, which I think has been particularly challenging in my clinic, where patients tend to be older or need a second set of ears and eyes in the clinic to understand the treatment plan and to voice all of the things that they've been experiencing at home. We've tried to manage some of that by calling our patients ahead of time. We have a nurse coordinator in our clinic who has been spending a lot of time on the phone talking with patients and their families and reassuring them that we're taking all of the measures that we need to reduce their risk when they come in. We've been able to try to streamline our appointments, that it's more of a one-stop shop instead of going to multiple places on multiple floors within the building, so that those individuals can come in by themselves, know exactly where they need to go and leave without having to, potentially go to the wrong place or miss an appointment or be exposed to multiple different providers. So I think that, and I think the other thing that we're doing is trying to reach, instead of canceling appointments and just rescheduling down the road, we're scheduling telemedicine visits where we can interface and interact with a video to to really see those patients. And I think that just this week, I've had some very touching interactions with patients through the video conferencing that I think was very beneficial to them and to me, so that we're both reassured of exactly what's going on, and knowing that we're here to help, whatever the situation may be, and that we're not just cutting them off and telling them to reschedule months down the road when the situation changes. So I think the patient advocacy groups can really be very helpful in this situation. Oftentimes, these groups are the eyes and the ears of the patient community, and I think that obviously care delivery and the way we're managing COVID-19 is different from facility to facility, from region of the country to region of the country. And I think pulling some of the input from patients, well, what hasn't worked well, and assimilating that and providing that information back to physicians can be very useful. I think the other main way that advocacy groups and medical organizations can work together is to put together information for patients, particularly related to COVID-19 and cancer. We see a lot of information out there about COVID-19 in general and the risk to patients with underlying medical conditions. But I think that the cancer population is a unique one, and the types of therapies that we deliver. And I've had a number of patients ask me, is my condition an underlying condition that I keep hearing about in the news, or I'm getting immunotherapy, am I immunocompromised? And I think a lot of that those types of answers can be given back to patients in sort of guideline format or COVID-19 statement format, and can be put together by medical organizations that would be useful tools, I think, for physicians to know what the data is and know what the science is behind this, particularly as we build databases for cancer patients and as we get more information about how cancer patients are faring if they do contract COVID-19. Pulling that information together and providing it in a format that patients can access would be very useful. So I think lung cancer is a particularly challenging diagnosis to have in the era of COVID-19. Most of our patients, or a significant number of them, have had prior smoking histories, have underlying COPD or lung ailments. Obviously, having tumors in the lung potentially makes them more short of breath or at risk from hypoxia at baseline. We have therapies that are known to increase the risk of pneumonitis. Immunotherapy is one that we all know about, but even oral TKI therapy can result in pneumonitis. And I think we have a lot of unanswered questions about if a patient does contract COVID-19, what is the relative safety of continuing those therapies? If they're held, what is the safety of resuming those therapies after COVID-19 has abated? And I think that poses a real challenge for my specialty in lung cancer. And we'll have to see how some of this data evolves over time. And as we collect more information, I think erring on the side of caution and holding therapies for patients who contract COVID-19 and having careful conversations about the utility of resuming. And I think the other aspect here is when you're thinking about starting a new therapy with patients, you have to weigh the risks of COVID-19 in your local communities. What's the risk of contracting it? Is the prevalence high enough that exposing someone to a second line chemotherapy drug that may put them at increased risk of immunocompromised status? And what benefits are we getting from that? I think all of these things need to weigh into our risk benefit analysis, where there was a different balance before this time frame. But I think we need to take these things into consideration. And in some patients, it may be appropriate not to recommend therapy, where if COVID-19 was not here, we would otherwise recommend it. So I think these are a lot of challenges that we face. And I think that we can overcome this and we can adapt to this. We can modify our clinical practices to keep patients safe and distanced. We put through telemedicine and doing infusion-only visits when patients are doing well, or delaying infusions for those that are doing really well. But I think the importance is taking the extra time to individualize care and really weigh the risks and balances of all of the things that we do.